Hello, friends. Today we are going to discuss the case which had this intracranial bleed after thrombolysis with Alteplase. So we had this 66-year-old male patient who was a known case of diabetes mellitus and hypertension. He presented to us with the chief complaint of right-sided weakness, diagnosed with the left ACA infarct. He was thrombolized with Alteplase. Next day, patient's GCS was dropped. So we have taken CT brain, which showed intracranial bleed. So the next question is how to manage this intracranial bleed, which developed because of the thrombolytic agent. So classification of this intracranial hemorrhage after thrombolytic therapy is typically based on two main factors: the radiographic appearance of the hemorrhage and presence of associated neurological deterioration. So what are the risk factors and prediction score? A number of clinical, lab, and radiographic factors associated with the risk of ICH after Alteplase have been reported, and they are older age, greater stroke severity, higher baseline glucose, hypertension, congestive heart failure, renal impairment, diabetes mellitus, ischemic heart disease, then atrial fibrillation, baseline antiplatelet use, leukoariosis, visible acute infarction on brain imaging were all associated with the increased risk of this intracranial hemorrhage. Current smoking was associated with the reduced risk and statin use. So stroke severity assessed by NIHS is one of the factors most robustly associated with the intracranial risk. Now, what is the pathophysiology behind it? The development of post-thrombolytic hemorrhagic transformation requires multiple and interconnected pathological processes, like including ischemic injury, coagulopathy, disruption of the blood-brain barrier, and the reperfusion injury. So, intracranial hemorrhage is attributed to Alteplase, which occurs within 36 hours after infusion, with only half of the event being diagnosed by 5 to 10 hours after Alteplase infusion. It is possible that extending the period of neurological and cardiovascular monitoring every 30 minutes from 8 to 12 hours may lead to an earlier diagnosis of intracranial hemorrhage, particularly in high-risk patients. But this strategy requires assessment in the larger prospective studies for cost effectiveness. The neurological deterioration in the setting of intracranial hemorrhage may be less pronounced with increased stroke severity. Therefore, lower threshold to trigger emergent repeat imaging may be considered in patients with high NIHS score. That is, NIHS score of more than or equal to 12. So if we have one patient whose NIHS score is more than or equal to 12, then we should be more vigilant uh, regarding the GCS score and power or any new onset of focal deficit, and we should keep very low threshold for CT brain. Now the indication for treatment. Overall, currently available literature suggests that intracranial hemorrhage within 24 hours of the Alteplase therapy or with hypofibrinogenemia might be the reasonable indication for the treatment. Although very limited data are available to support the treatment of asymptomatic bleeding, the use of reversal agent for any asymptomatic parenchymal hematoma occurring within 24 hours of Alteplase infusion may be considered, particularly in the setting of ongoing coagulopathy. So this is the important slide of this lecture, which showed what are the what all agents that we can use for treating this intracranial hemorrhage that occurs within the 36 hours after Alteplase infusion. So the first one is cryoprecipitate. So whenever we are dealing with such a case, we should send fibrinogen level immediately, and we should empirically transfuse the 10 unit of cryoprecipitate and anticipate giving more cryoprecipitate as needed to achieve the normal fibrinogen level of more than 150 mg per day. So 10 unit of cryoprecipitate will increase the fibrinogen by nearly 50 mg per day. So the potential for benefit, it has a potential for benefit in all intracranial hemorrhage. And the adverse reactions are transfusion reaction and transfusion related lung injury. So next is platelet. We can also transfuse platelet, that is 8 to 10 units, but the potential for benefit is unclear except in patient with the thrombocytopenia. That is, if the platelet count is less than 1 lakh, then only the transfusion of the platelet will work. Otherwise, the potential of the benefit for the platelet transfusion is doubtful. Now, what are the adverse effects? Adverse effects are transfusion reaction, transfusion related lung injury, and volume. Now, the next line of treatment is FFP. FFP we are transfusing in the amount of 12 ml per kg. Potential for benefit is unclear except the patient is on the warfarin, in whom FFP can be helpful. And the adverse reactions are transfusion reaction, transfusion related lung injury, and volume. The next line of treatment is prothrombin complex concentrate. So this we can administer based on the INR level, but roughly we can transfuse 25 to 50 units per kg. So for PCC also, potential for benefit is unclear, but it can be useful in patients who are on the warfarin. And the adverse reactions are thrombotic complications. Now, the next line of management is the vitamin K. This we can administer in the dose of 10 mg intravenously. Potential for benefit is unclear except for the patient who are on the warfarin therapy, in whom vitamin K may be used as adjunctive therapy. Now, the adverse reaction of the using vitamin K is anaphylaxis. Now, the next line of treatment is the recombinant factor 7A, which we can use in the dose of 20 to 160 microgram per kg. Potential for benefit for the factor 7A is unclear, and the adverse reaction is the thrombotic complication. Now, the last agent that we can use is tranexam. Either aminocaprionic antifibrinolytic, either aminocaprionic acid or tranexamic acid. So both of these agents are antifibrinolytic agents. Aminocaprionic acid can be used in the dose of 4 gram IV during first hour, followed by 1 gram per hour for 8 hours. And tranexamic acid can be used in the dose of 10 mg per kg 3 to 4 times per day. Potential for benefit in all patients with the intracranial hemorrhage, particularly when blood products are contraindicated or declined by family or patient or family, and if cryoprecipitate is not available. Adverse reactions are thrombotic complications. Now, how to prevent this hematoma expansion? Healthcare providers should weigh the risk of worsening ischemia against the severity of the hemorrhage and expansion risk to decide on the blood pressure goals. The patient with incomplete recanalization and the higher blood pressure target may be necessary to maintain the adequate blood flow to the ischemic bed and to reduce the risk of infarct growth. But the patient with the full recanalization, then the strict blood pressure control should be there. The safety and efficacy of this approach needs the further investigation. Now, about the neurosurgical treatment may be considered in selected patients with intracranial hemorrhage for whom surgery may improve outcome despite the ischemic injury. Careful consideration should be given to patient to whether this potential benefit outweigh the risk of hemorrhagic complication in setting of possible Alteplase associated coagulation. So my take-home message is uh, if the patient's NIHS score is more than or equal to 12, and if we are planning to thrombolize the patient, then please keep then please monitor this patient aggressively post thrombolysis and keep the low threshold for CT. Even if there is a slight change in the GCS or if slight change in the power, and if the patient is not responding you properly, then do the CT scan of the brain immediately. And if you find this intracranial bleed in that CTU image, then treat the patient with the cryoprecipitate, because send the fibrinogen level immediately and treat the patient with the cryoprecipitate. In case if the cryoprecipitate is not available, then tranexamic acid, and if the patient is on the vitamin K, we can go for the prothrombin complex concentrate, vitamin K, and other agents. And we can also transfuse the FFP and platelet. But the platelets are only useful in the patient whose platelet counts are low. And again, FFP if the patient is on the warfarin, and the FFP is the dose of the FFP is based on the iron. Thank you, guys.